Hi everyone, this is Dr. Jordan and this is an overview of evaluation and management coding for nurse practitioners. Prior to this lesson, please make sure you have reviewed all materials. So we're going to review what is E&M coding, what are the difference between well and sick visits, how do we select proper codes, what are the three key components of E&M coding, how do we assign a level, and then the application in the typical nurse practitioner environment. So what is E&M coding? Evaluation and management coding is simply the numerical assignment of codes to submit to reimbursement payers for services that require an evaluation and a management or decision making by a clinician of a patient. So patients can be seen in multiple types of settings and multiple types of visits, and E&M coding allows us to categorize those types of visits by several categories and then assign the proper numerical code to represent a standardized level of service across all providers. So how do we start the process of selecting a code? First, we have to define the type of patient we are seeing. If the patient has not been seen by you or anyone else in your practice of the same specialty, then they are considered a new patient. Otherwise, they are an established patient. We need to define the type of setting that they're being seen. Is this inpatient, outpatient, emergency room, skilled nursing facility, and so on. Then we need to determine the level of service that we have provided, and those are separated into four categories: problem focus, expanded problem focus, detailed, and comprehensive. Now we also, of course, need to know if we're treating a patient who is well today in terms of their health status or if they are sick. Well visits are much easier to code than sick visits. We call this preventive medicine, and it is simply delineated by whether they are a new or established patient and how old they are. So all we need to know are those two factors, and we can assign a preventive medicine code. Now, it's important to remember that preventive medicine or well visits are only applicable for patients who are actually well. So if someone comes into the office and they were scheduled for a well visit but are actually feeling sick today, that is a different type of visit, and we cannot bill a preventive medicine service with a sick visit diagnosis. We'll talk a little bit more about that as we move along. Now, there are three key components to assigning an evaluation and management code, and these are crucial and cannot be ignored when we are assigning proper levels. So those three key components are history, exam, and medical decision making. And history is made up of the following elements: the chief complaint, the history of present illness, the personal, family, and social history, which we affectionately call FISH, and the review of systems. Now, all of those components have individual categories and elements within them that are defined in the documentation that you were assigned for reading. So I won't repeat these here, but please refer to those materials to see the more detailed information. Exams are made up, of course, of objective findings and subjective findings. And of course, objective findings are things that the clinician actually observes and can measure, and subjective findings are things that the patient tells you, such as, "It hurts when I do this." Medical decision making is made up of three main elements, and that is the number of diagnoses and or complexity of the condition for the patient, the treatment options for the patient, and the risk of what your decision might mean for that patient. So for example, if I do this, will the patient get more sick or possibly die? If I do nothing, what might happen? So those are the three main elements of decision making. And because decision making is often the most difficult to assign, because the other two categories have templates that you can follow and are determined by number of systems you review and so on, but medical decision making, and particularly the risk category, is the most difficult for clinicians to evaluate. So I have put up an example, a table, to help illustrate how we determine the level of risk for a patient. So for example, minimal of course might be someone who has an insect bite or a splinter, something like that, where we have minimal if any diagnostic procedures to review. The management options are usually self-resolving. So in other words, if you did nothing, if that patient had not come in for the encounter, that symptom or that illness would typically resolve on its own without any medical intervention. That would be considered a minimal risk. Low, of course, goes another sort of step up in terms of things that would resolve with minor intervention, such as over-the-counter drugs, perhaps a minor surgery to like remove a mole or something like that that could be done in the office and so forth. So these are things that, again, are not necessarily self-limiting. They may not resolve on their own, but if we didn't treat it, it probably wouldn't grow into anything worse. So that's the low level of risk. And then moderate and high are, these are the two areas. Deciding whether or not it's one or the other of moderate or high is really where some detailed examination needs to come in. So you can see the difference between the two, particularly when we talk about the types of conditions. So a moderate level of risk is someone who, may have one or more chronic illnesses that is normally fine but might be a little irritated today. They might be coughing a little bit more and so forth. Or it might be a sudden acute illness that may have systemic symptoms or may grow into a system-wide problem. Of course, an acute complicated injury where there could be multiple reasons or multiple comorbidities to go with it definitely increases the risk as well. And then, of course, high risk are abrupt changes in neurological status, having a seizure, having a heart attack, multiple traumas, things like this where your decision making could really be the difference between life and death. So this is a good table, and there are many available out there on the internet and through different vendors that helps you decide what level of risk you're actually operating under. Now, how do you select E&M codes? And this is a somewhat complicated process, but throughout the three key elements I just explained, history, physical exam, and medical decision making, there are levels that are assigned to each one of those categories using the criteria that was available in the prior documentation, and then assigning that based on whether the patient is new or established. So in the first table on the upper left, those are new patients, and those are the categories and the levels that you need to meet to assign those codes. And on the bottom right is a table for established patient in the outpatient setting, and those are slightly different. If you compared the two, you would see that new patients need to meet 3 out of 3 components to select that code, and established patients only need 2 out of 3 to meet the level. And again, this is just a snapshot. The process of selecting a code, like I said, is very complicated, and typically a certified coder would do this sort of work, but this is an overview to orient you to what the categories are and what the different levels mean. Now, as a nurse practitioner using electronic health records, you will encounter probably in your career many different templates if you have not already. And these templates are designed by vendor, by provider, by healthcare organization. They can all look different, but they typically all include the same thing. For the office or the outpatient setting where you are doing evaluation and management services, they will have the 3 key components: history, exam, and medical decision making. They may look slightly different. The checkboxes might be in different areas and so forth, but they are all going to ask you or provide a space for you to document those 3 key elements. Now here is an example of another one that might have a little more free text. This one is a multi-specialty example, but you can see on the left where they have a person who comes in, the items that we mentioned, chief complaint, for example, the history, the present illness, review of systems, the exam, and so forth. And it gives you the place to document all the items that you might have to review, like diagnostic, lab, or x-ray, for example, what's the plan, the prescription, and so on. Most of these systems will help you assign a code. They will often, based on the documentation and the checkboxes you provide to the EHR, will suggest a code or at least a category for you to decide where you are in the evaluation and management levels. Here is an example of an encounter form or super bill for evaluation and management codes, and you can see that this one is a template that's from an EHR. Typically, as I said, if you have completed all of your documentation for the visit, one or more of these areas might be highlighted or already checked off for you. So for example, a well visit, if you select a patient who's 4 and you complete all the well visit template that's in the EHR, well, when you come to this screen, it's going to have either 99382 or 392 checked off already for you, because that's very straightforward. It's by age and it's by well visit and it's new or established, so that's done. But for sick visits, it might be 1 or 2 highlighted for you, and then you have to decide, because you're the clinician, which appropriate level was this, based most of the time on your medical decision making. So just a final word about diagnosis coding. Diagnosis coding, you are typically in a nurse practitioner setting in an office, for example. You will have a template that comes up that may have the top 10, 20 or so diagnoses codes that are seen in your clinic. So things like upper respiratory infection and cough and otitis media and those types of things are going to be readily available for you because they're very common. So you can click them and choose them. Otherwise, you can search inside the EHR for that particular diagnosis, and the description and the code should come up all at once, and you can choose that and go forward. Now, if you're in a situation where there is not an electronic health record, which would be hard to imagine these days, but if that were the case, they may have a paper super bill or encounter form that has, again, the top 20 or so diagnoses codes that are seen in that office, and you would either circle the correct one or you would write it in. What I want to emphasize, though, is that we want to make sure that our E&M service, our CPT code, matches our diagnosis. So as I mentioned at the beginning, a preventive exam cannot have a diagnosis of a cough, and a sick visit E&M code cannot have a diagnosis of a routine child exam, for example, because those two things don't go together and they will be rejected and not paid. So you want to be careful that you're in the right ballpark. Now, I do want to just emphasize that most facilities and offices have coding staff or someone there who can help and assist you with selecting the right codes. And I urge you to do that. If you have any questions, you're much better off putting a question mark or sending that chart to the coder to help you assign the correct code rather than assign an incorrect code. I hope that you have enjoyed this overview and enjoy your experience with E&M coding.